Hello everyone. In the beginning, I'd like to thank Dr. Nada and Dr. Shaima for the kind invitation. My talk today about jumping into the deep and hands-on GI endoscopy training. Reviewing the ESGE guidelines about basic gastrointestinal endoscopy training, actually the ESGE and ESGE-NA consider the following as basic endoscopic procedure that should be known by every trainee. Diagnostic upper and lower GI with limited range of interventions such as tissue acquisition via the cold biopsy, forceps, polypectomy for lesion less than 10 millimeters, hemostasis technique, enteral feeding tube placement, foreign body retrieval, as well as dilatation of simple esophageal strictures and India ink tattooing of lesion location. Before starting the hands-on training, it's mandatory for the trainee to acquire basic knowledge about endoscopic anatomy, function, and technical characteristic of the endoscope, indication and contraindication of the procedure, as well as the KPI indicators. Knowledge regarding the pre-procedural management, such as bowel preparation and assessment of relevant patient history, obtaining informed consent, anticoagulation management, and management of immediate adverse effects are also an essential part of the training. In recent years, there have been a shift in the focus in assessing the trainee in GI endoscopy from the rigid numerical procedure into a competency-based educational model. The shift due to the observation that the trainee learning curve varied significantly in clinical practice. And the definition of competency has been evolved also beyond the motor and the cognitive skill to include an integrative skills, including the patient communication, leadership, and professionalism. That's a proposed structure for the training program for a basic gastrointestinal endoscopy. As we see, is beyond the cognitive learning through the educational activity, while live online and video courses, seminars, and case discussion. Motor skills, including orientation, observation, then a simulator, partial hands-on to complete hands-on, into an integrative skill that focuses on interaction with the endoscopy team, integrated patient management, and administrative and personal organization. And when we talk about the hands-on, there is a wide spectrum of the hands-on. We mean bench model, mechanical simulators, VI simulators, ex vivo tissue, and live-supervised patient cases, although most of the literature focuses on the live-supervised patient cases. This study was published in Journal of Gastroenterology and Hepatology 2024 about the comparison of simulation-based mastery learning versus conventional appearance-based learning for basic endoscopy training. And it found that the simulator-based learning resulted in a steeper learning curve, as the trainee learned 3 times more during the same period, as well as developed a uniform competency level at the end of the training. So why we need the push for an early hands-on experience? Actually, there is a rising demand for skilled endoscopists, for example, in Egypt after the implementation of the CRC screening initiative. Besides, it's part of the board requirement. Egyptian Fellowship Board requires competency, not just observation. And some studies show that the early hands-on lead to a faster skill acquisition. What are the advantages of the early hands-on training? Studies show that the 20% reduction in training time, so there is a shorter learning curve. Besides, trainees gains confidence and comfort with the procedure, besides diverse patient exposure to different cases during the learning curve. Also, some studies suggested that on the long term, early hands-on on the trainee reported fewer complications, besides improved detection with higher adenoma detection rate. So what are the expected cons and what are the expected disadvantages? Firstly, increased risk. There is an increased risk of perforation in the early training, of perforation, bleeding, aspiration in the initial cases. Some ethical consideration about balancing the training needs with patient well-being, which is crucial, but the key is the supervision. According to the ESG guidelines, there are limited data about the adverse effects related to the basic gastrointestinal endoscopic procedure. Generally, is considered safe once it's overseen by a dedicated trainer. Some studies, mostly retrospective studies carried out on the teaching hospital, showed there is no association between the training involvement and the adverse effects. Some of the prospective studies too found the benefit, and it was done firstly for the benefit of the simulators in the training program, but again found no adverse effects in involving the trainee in the procedures. Only 2 studies reported few risk effects due to the trainers, including short-term reversible changes in the vital function parameters such as transient hypoxia. On the other hand, prolongation of the procedure led to the potential sedation-related incidents and unnecessary exposure to radiation experienced by some of the studies. However, they are very unlikely that the participation of the trainee increased the risk of the adverse effects. It's inevitable that the procedure may be prolonged, leading to the adverse effects only in the vulnerable patient with comorbidity. But there is only one way to ensure the safety for the patient, which is that the trainer match the fellow current performance to the procedure in the patient to avoid unnecessary prolongation of the procedure. Again, what are the side effects for the hands-on, early hands-on? The higher stress levels. Trainee experience very high stress levels, potential for the burnout. Technical challenges also cause frustration, and the critical need for strong mentorship and support. How to reduce this? I suggest we should follow a graduated approach, starting for the patient, for the trainee, with the simple cases progressing to more complex one. Intensive stimulation using virtual reality simulators for the training, beside ensure close monitoring and immediate feedback. My conclusion, we have to balance the act between the potential benefits. Early hands-on training has potential benefit. It requires careful planning and execution. We should invest in simulation and mentorship program, and we should prioritize our patient safety through structured training. And thank you.